Hi, my name is Daniel, and today I'll be presenting my technology evaluation on cdmNet. So I'll be running through several points quickly. First, I'll be talking about the context of chronic disease, or why I chose to evaluate cdmNet in the first place. I'll then move on to talking about where I gathered my data from, and what cdmNet actually does. I'll then talk about how I chose my evaluation frameworks, the evaluation itself, and what I've learned from the project. It is difficult to pin down a precise definition of what a chronic disease is, but there are some words the WHO and the Department of Health use to describe conditions considered to be chronic, which are long duration, gradual onset, slow progression. Treatment can aim to cure the disease, but more commonly all that can be done is to manage the disease by delaying progression and preventing or decreasing death, disability, and hospitalizations arising from them. Examples of common chronic diseases include diabetes, ischemic heart disease, lung cancer, depression, and osteoporosis. Why is chronic disease such a big deal? The statistics can be staggering, with over 1/3 of Australians suffering from at least one chronic disease, not to mention the immense associated healthcare costs and years of healthy life lost. So the chronic care model has been around for many years, and it aims to transform care from reactive to planned, proactive, and preventive. It has the potential to decrease hospitalizations and death, as well as improve quality of life and reduce disability and complications from disease. Australia has had a chronic care framework in place for 15 years as part of Medicare. It started in 1999 with the EPC package introducing Medicare items for multidisciplinary care in chronic disease, and this was replaced in 2005 by TDM items. So the Medicare benefit schedule items describe various tasks carried out by healthcare providers, as well as the reimbursement from Medicare for each task. This table shows the chronic disease items claimable by GPs, most prominently for creation of GP management plans and team care arrangements, as well as the reviews of each. A GP management plan can be made for patients with a medical condition present or likely to be present for at least 6 months, and a team care arrangement is an extension of that for patients who require ongoing care from at least 2 other allied health providers. So these are the items claimable by allied health from Medicare if a patient has both a GP management plan and a team care arrangement and is referred under the team care arrangement. How it normally works is that the GP faxes a referral form over, the allied health provider signs acceptance and faxes it back, and the GP has to then approve the TCA and collate all the progress reports later on. Given the clear financial incentives to GPs and allied health professionals, and the evidence that patient outcomes are improved, it is surprising that only 14 to 26% of patients with a chronic disease have a GP management plan, and 13% have a team care arrangement. Only 20% of these are regularly followed up at the recommended frequencies. A study shows that the major barriers to uptake have to do with the excessive time taken up by phone calls and faxes to organize these community services, the sheer complexity and administrative overhead this entails, lack of information on patient eligibility, and a fear of issues with audits in the future if there is a problem with the paperwork and follow-ups. This all contributes to the general feeling that CDM items don't deliver value for the time invested. So this slide deals with where I gather information from. On the left are the main websites I use to search for data, and on the right is a list of some of the search terms that were used. So what is cdmNet and what are its goals? cdmNet is an online web-based service from Precedence Healthcare, which aims to support the whole process of chronic disease management in the primary care setting for the entire care team, including GPs, practice nurses, practice managers, allied health professionals, and patients. By streamlining all of the administrative processes, cdmNet is being positioned as a one-stop portal for chronic condition care. It has been endorsed by the Royal Australian College of General Practitioners as a useful product supporting GPs in managing chronic disease. So this slide runs through a typical usage scenario. Providers and possibly patients have to create an account through the web portal. GPs must further install a desktop download on Windows, allowing for integration with their clinical desktop software. At present, only two software supported, which are Best Practice and Medical Director 3. cdmNet will then automatically prompt the creation of a GP management plan for eligible patients during a consult. The GP selects the conditions for which the GP management plan is to be created, which is then automatically populated with best practice goals and tasks. A review date is set, and the team care arrangement can be created if desired. The TCA is distributed to selected allied health professionals for their agreement, and the GP is prompted to approve the plan when 2 or more confirmations are received back. The GP is also prompted for review automatically when it is due. Patient access is possible, but is limited to entering their blood pressure, weight, and other readings, as well as progress notes from non-GP referred allied health appointments. So this slide shows the creation of a GP management plan, where evidence-based goals are automatically entered, and tasks are color-coded according to the professional responsible for them. So cdmNet provides several free services, such as the shared electronic health record, collaborative features for health providers and patients, and support for patient self-management. Where it makes its profit is by charging GPs fees whenever CDM MBS item is claimed. So in looking for an evaluation framework, I identified several criteria which I felt were important, given the context of cdmNet being both an administrative and clinical decision support tool. These included return on investment, clinical outcomes, being based on best practice, and the social technical aspects. I evaluated 10 frameworks against these criteria and decided to go with a hybrid, using the CHEATS framework as the main evaluation tool, as I felt the categories are broader and encouraged a more comprehensive overall view of the product. However, the strength of the KDS framework was the amount of detail in the analysis, and therefore many questions and factors were drawn from KDS to inform evaluation within the appropriate CHEATS categories. So moving on to the evaluation proper, I will be presenting some highlights from each of the CHEATS framework evaluation categories. The first is clinical. 2 studies of diabetes patients were done, showing that GP management plans and team care arrangements resulted in good outcomes of patients, mainly when regular reviews took place, and cdmNet increased the likelihood of regular review by 4 times over the national average. However, there were no studies available in other conditions. cdmNet also improved patient safety through increasing adherence to best practice guidelines. So in terms of human organizational factors, most patients were happy with the GP's use of cdmNet and the handling of their private data. But an interesting finding was that only 35% believe a GP management plan will help them to control their condition better. Issues with health providers included a reluctance to invest the time and money to change, and the necessity for a critical mass of providers to start using the system before it became attractive. In terms of education, health providers who went to workshops for cdmNet felt that it increased understanding of the role of GP management plans and team care arrangements in managing chronic disease. It also increased interprofessional coordination and learning. In terms of administration, convenience was achieved mainly through digitization and the creation of an audit trail, and GPs typically increase their earnings by around $45,000 annually without having to spend extra time. In terms of the technical aspect, cdmNet was found to be accessible, scalable, and secure, but limited by a lack of software standards among vendors and aging infrastructure. In the social dimension, there were minor concerns that digitization could lead to a reduction in interpersonal contact during phone calls, to the detriment of interprofessional relationships. In conclusion, cdmNet is a well-developed, comprehensive tool fulfilling its primary objectives. However, uptake has been limited by perceptions that it's not worth the investment and effort to change, a lack of health outcome studies for conditions other than diabetes, and compatibility issues outside of cdmNet's control. There are also other opportunities for further studies, with the last point being that while financial incentives for primary care providers are clear, a cost-benefit analysis needs to be done from a Medicare perspective. Previous analysis would have been skewed by the tendency of GPs to only bother creating GP management plans and team care arrangements for the most ill patients. A much wider population-based approach facilitated by cdmNet means Medicare reimbursements may need to be adjusted accordingly. And finally, here are the references that I used. Thank you.